Um, all right, well, I will start with introductions. Welcome to Department of Medicine Grand Rounds today. It's October 17th, for those of you guys who weren't already aware. And I'm excited to welcome two of our faculty members from the Division of Pulmonary, Allergy, Critical Care, and Sleep Medicine today. They will each present a portion of this. I'm going to go ahead and introduce both at the top of the hour here and let them make the switch in between. So first up is going to be Dr. David Neujahr. He's an associate professor of medicine and the medical director of the McKelvey Lung Transplant Program, which is part of the Emory Transplant Center. Dr. Neujahr joined the faculty in 2006 after completing his pulmonary critical care training at the University of Pennsylvania, where he studied T lymphocytes and their resistance to co-stimulatory blockade after homeostatic reexpansion. Here, he seems to be ever present in the lung transplant world, including working with the Emory Transplant Lab, looking at T-cell biomarkers preceding the development of chronic graft failure, collaborating with Dean Jones on metabolomic signatures associated with pulmonary fibrosis. He has worked in clinical studies like the large influenza study looking at transplant patient immunity towards influenza. And he has, I think, a significantly large clinical footprint with seeing pre- and post-transplant patients in clinic and on the inpatient service. And I'm always grateful for his counsel. Second, Dr. Vibha Lama joined Emory just this past May. She is the DOM's new vice chair of research, holds the Augustus McKelvey Chair in Lung Transplantation Medicine, and is the director of the new Comprehensive Lung Disease Center within the Pulmonary Division. She is renowned nationally and internationally for innovative work in the fields of lung-resident mesenchymal stem cells and regenerative and fibrotic pathways in adult lungs. Her research is NIH funded and has been so continuously, and it spans clinical and basic science arenas. In her translational research program has contributed significantly to the understanding of fibrotic lung disease and chronic rejection post-lung transplant. She, among her many distinctions and long CV, is an elected member of the American Society for Clinical Investigation and the American Association of Physicians. So thank you guys both so much for joining us and getting us up to speed on some of the excitement in the lung transplant world. You guys, I think the title of your talk is Challenging the Status Quo via Innovative Care and Research. And so I'm excited for this tour de force, and I'll turn it over to you, David.
Thank you. So the objectives for today, what I really want you to know is I want the audience to understand what the current trends are in transplant. I'm going to spend some time talking about candidate selection. I'm going to hit what I think are the big controversies right now. And I also have to talk a little bit about transplant allocation. And then Dr. Lama is going to really talk about the future, focusing on what we call CLAD, or chronic lung allograft dysfunction, which I think of as the kind of the sword of Damocles hanging over our patients' heads. And she'll talk about mechanisms and prevention and possible treatments and the future. So I want to start with a case, and I chose this case because I think it captures a lot of the themes of this talk. And encapsulates a lot of important concepts relevant to transplant. So this really happened. This is about 2 years ago, a little over 2 years ago, winter of 2021, before COVID vaccinations had taken hold.
David, can I interrupt? Are you showing slides?
Yeah.
Because you're not.
Oh, hang on.
Say the same thing.
That's too bad.
I thought maybe you were going to do the whole, talk,
I'm looking at slides. Hang on. How about, can you see them now?
Yes.
No.
Okay, cool. Well, back to this. Anyway, slide. So this guy, we got called because there was a guy at Wellstar. You guys can see my slides, I hope.
We sure can.
Okay. There's a young guy, 53. 53 is young. And totally healthy, and he gets COVID. And he gets on the vent, and things don't go so well, and he gets put on ECMO, which is essentially artificial lung. And he's there for a month, and they can't get him off. And they call us, and they say, hey, what do you think of this guy for a lung transplant? And we'd never done that before. We had transplanted patients off of ECMO in the past, but this was our first COVID case. And so we brought him over, and you know, the CT scan shows his lungs. Lungs are supposed to be black on CAT scan. You can see there's a nice white thing in his SVC, which is his ECMO cannula. He's got a couple chest tubes in. And we worked him up. We did, you know, cardiac testing, kidney testing, liver testing, all that stuff. He's wide awake. We actually take him off the ventilator. We start walking him in the hospital in the 5E ICU. So he's doing laps while connected to ECMO. This is a little letter that he wrote to our nurse practitioner asking if he could eat. We actually let him eat. So it was kind of weird to see a guy on ECMO ordering meals, but that did happen. And we put him on the transplant list. At the time, the scoring system was called the LAS, and he had a super high score. Within a couple days, we got a donor for him and we transplanted him. So that was great. He had some of the typical early complications after transplant. He had pulmonary edema, which we call primary graft dysfunction. The middle pane shows his June x-ray, which I think actually looks pretty good. This little bow tie in the middle is his sternal wires that everybody gets as kind of a memento of their transplant experience. And then actually put this on one of our transplant Christmas cards, but we caught him in the hallway coming in for labs, and he ran into that same nurse practitioner and snatched a picture. And if you didn't know he had a lung transplant, you would just think he was a regular guy. He's back to work. He's traveling with his family. He's living his life. And right now, 2 years and change after his transplant, he's basically normal, which is great. That's why we do this. And so that kind of raises the question of like, how common is this? Is this something that we do a lot? And this is data that I'm showing from what's called the OPTN. That's the Organ Procurement Transplant Network. They have publicly available data slides, and they go into a lot of depth about transplant volumes in the United States. If you look here, what you will see is that in an average year in the United States, we do about 2,500 lung transplants. So collectively, going back to the 1980s, we've done about 51,000. So it's a pretty modest number. I mean, if you think about how many people in the United States have end-stage lung disease, the number of people that are actually helped with transplant is very, very low compared to that number. Just to point out, our own program at Emory, we've done almost 600 lung transplants at this stage. So we have a nice growing cohort, but it's still relative to, say, kidney transplant, where they do 25,000 transplants nationwide a year, pretty small numbers. So what can my guy that we transplanted during transplant patient expect to happen? I mean, he's doing great now, but is that going to hold up? So I want to show you some data from our professional society, which is called the International Society of Heart and Lung Transplant. And they have really nice registry slides, which are also publicly available, going back to the 1980s. And what's shown here are Kaplan-Meier curves for patients who receive a double lung transplant or bilateral in black, or a single lung transplant in red. And what you see here is that the median survival of the double lung transplants is about 7.8 years. It's a little bit less for single lung transplants. And so the question is that good? It's hard to say because, you know, if you're like our first patient, you would 100% take these odds because that guy was facing certain death without transplant. But it becomes much harder for patients who are stable but sick, who have end-stage lung disease, and whom they're trying to decide, is it worth it for me to get a lung transplant or not? The other thing I take away from these data is simply the fact that there's such a wide variety of outcomes. And so when I'm counseling patients in clinic, I'm saying, you know, you have a pretty good chance of living a year, and you have some chance of living 20 years, and it could be kind of anything in between. Now, relative to other solid organ transplants, lung transplant lags behind in terms of survival outcomes. This is data, again, from the OPTN and the Scientific Registry of Transplant Recipients. This is US data. And on the top, you see kidney and pancreas are actually superimposed. It's 2 lines there. They have great overall survival. And for the case of kidney, they also have a backup therapy, which is dialysis. Lung and liver, heart and liver are slightly below that. The blue line is our as lung transplant. And there is actually another transplant, small intestine or small bowel, which has even worse survival than lung transplant. I would highlight that there are probably some similarities between small bowel and lung. Namely, the lung is actually an embryologic foregut derivative, and both tissues have extensive lymphatic tissue. And so there may be something about the biology of lung and intestine transplant that simply makes it harder than the other types. I don't think it's related to the fact that the physicians are worse. I think it's more related to the biology of the tissue. The other practical issue that our patient is going to face, and all of our patients, is that there is a very high immunologic hurdle after transplant. And so this is actually a picture of one of my mentors, Alan Kirk, where he held out the total number of pills this is from a kidney transplant has to take per day. It's similar in lung transplant. And because the drugs are bad for you and cause high cholesterol, high blood pressure, anemia, propensity to infectious diseases, diabetes, and a number of other side effects, when you add up the total burden of medications that our patients are taking, it is easily sometimes 15 or even 20 medicines per day. So I would say that given how complex the stakes are and given some of the uncertainty about outcomes, it's really important for us to have a very drilled down, protocolized way to select patients. And on the right, you see a little cartoon of, this was several years ago at Emory, our total transplant throughput. We saw that year about 500 distinct new consults. Patients I saw in clinic had discussions with about transplant. And out of 500 consults, about 100 of those patients, 1 in 5, we put through all the steps of an evaluation. And after we did that, 40 out of those 100 got listed for transplant, and then we did transplants on 30. So what you can see is that, less than 1 in 10 patients that are referred for transplant actually end up getting transplanted. And there's a number of reasons why they might not get transplanted. But it's important to know that there is a significant funneling off of these patients. The ISHLT puts out a white paper every several years, asking experts in the field to come up with generalized recommendations about who should be listed. The guidelines suggest that we should transplant patients who have a greater than 50% chance of dying from their lung disease in the next 2 years, which makes sense to me, and who have a pretty good chance, greater than 80%, of living 5 years after transplant related to other medical issues. And so basically, we want to transplant people when they're sick enough to transplant, but not too sick. And so that concept is called the transplant window. And what this cartoon is showing is that as patients get sicker and sicker in their disease trajectory, they're going to fall into a Goldilocks or sweet spot where a lung transplant makes sense. If we transplant them too early, we may shorten their lives just because of the complications involved in the transplant. And if we transplant them too late, they may also not generate a benefit because they may have too many medical comorbidities that limit their lifespan. The other thing I'd point out is that window may be different depending on what disease they have. Patients that have idiopathic pulmonary fibrosis, the #1 indication for transplant, likely have a shorter window than a patient with COPD, in which lung transplant may confer more of a quality of life than a survival benefit. The other thing that makes my job fun and also complicated is the fact that medicine keeps getting better. And the top 3 diseases that we transplant for, IPF, COPD, and cystic fibrosis, all have relatively new competing therapies that complicate the calculus. So for example, IPF, there are 2 FDA-approved drugs, pirfenidone and nintedanib, which may not cure the disease, but may slow it significantly. In COPD, we have the option of doing bronchoscopic lung volume reduction or even classical surgical lung volume reduction. And I would point out, for people that have rounded on 6G, 10 years ago, we used to have like 15 cystic fibrosis inpatient. Now you have 3 or 4. Most of that is related to new medications like the modulator Trikafta, which significantly slows down the progression of disease for patients with delta F508 mutation. In fact, if you look at our CF patients that we've transplanted in the last 5 years, most of those patients have a mutation which is not amenable to modulator therapy. I would also give an honorable mention to multimodal therapy for pulmonary hypertension. Pulmonary hypertension was one of the original major indications for lung transplant, and it's fallen off a lot because we have a whole toolkit of medications, and some even coming down the pipeline, which may reduce the tempo of that disease. So this is a busy slide, but the important take home here is that if you look at all of the major indications, these are the big five, each of those has its own specific criteria for transplant so that we can customize just when a patient is sort of in the transplant window for their disease. This is nice to have. One of the things I would say as a tertiary referral center is we get plenty of patients that don't fall into any of these categories. I'm now seeing patients that have COVID fibrosis and I'm not quite sure what to do with them, or rare orphan diseases like short telomere syndrome, or a couple of weeks ago, we did a transplant on somebody who had a disease called lymphangioliomyomatosis, LAM, and that's a disease that maybe a pulmonologist will see once or twice in their career. A big question that everybody asks me, providers, referring physicians, patients, even my own surgeon, says, should we do 1 or 2 lungs? And this is a hotly debated subject, and there isn't one great answer. My bias, the take home for me, is that we probably don't do enough single lung transplants. Right now, worldwide, 30% of our transplants are singles. The benefit of a single lung transplant is that a single donor can help 2 patients. It also has a shorter post-transplant recovery. It may have a shorter time on the wait list. And interestingly, if you look at VO2 max, sort of athletic performance of lung transplant patients, patients with a single lung or a double lung have essentially equivalent VO2 maxes. There are some cases where you should definitely do a double. You should do a double if somebody's very young. If they have suppurative lung disease that you're not going to cure with a transplant, then I think a double is preferred. I would say most of my patients would like to have a double because they just have this idea that 2 is better than 1. Now, there is some data on this. This is a large study that was published in JAMA a number of years back, looking at the US experience from the UNOS registry. The top 2 graphs show Kaplan-Meier curves for patients with IPF, unadjusted and adjusted for medical comorbidities. And there is a statistically significant survival benefit in that cohort for double lung transplant compared to single, although it is quite small. And when you look at patients with COPD, that actually, when you adjust for confounders, that completely goes away. So I think there's a role for double and a role for single. It's very complicated, but we probably don't do enough single lung transplants. People ask me about age. When I was a fellow, we wouldn't ever consider transplanting patients over 65. One of the things that I think has happened is a lot of my mentors have now become over 65, and we've started to rethink that. Age is a marker for frailty, which is a physiologic construct that really talks about resilience. As we all know, there are patients who are well over 65 who look pretty robust. And there are at the same time, there are patients well under 65 that look like they could be knocked over by a small breeze. And so one of the hurdles is figuring out how to tease those apart. I will say that today, about 30%, a little bit more than 30% of the transplants in the United States, or listings there in the United States, are for patients over 65. So this is SRTR data. This is also publicly available, gets published every 6 months. And it's a way that you can look at our center and other centers and compare them. And they have a bunch of different outcomes. This is just listing data. And in the most recent cohort at Emory, 25% of our patients are over 65, and in the United States, it's 33% of patients are over 65, including almost 12% of patients nationwide that are over 70. And we don't have a whole lot of clarity on the outcomes of those patients that are over 70. So, age is a number. It is a predictor to some extent about survival. So I'm not saying that all 65-year-olds are equivalent to younger patients. This is again OPTN data looking at different cohorts. I think what's real interesting about this data, so the green is the over 65s, and they lag a little bit behind the other age groups. But the second worst age group is actually patients between 18 and 34. And so that may actually be picking up a signal of medical non-adherence in some of the very young patients who are transplanted. There is a sweet spot, people in their 30s and 40s seem to have the best overall survival. So talking about frailty, a number of people have dipped their toe into trying to quantify frailty and come up with, the best markers for when we can transplant patients. This is an older paper from a friend of mine, David Lederer at Columbia, where they took the UNOS registry of patients that had idiopathic pulmonary fibrosis. And what happens is when you list a patient for transplant, one of the things you have to do is list their 6-minute walk test distance. And so they were able to show that patients who had IPF, idiopathic pulmonary fibrosis, if they had a 6-minute walk test distance that was lower, those patients had an overall worse survival at 1 year than patients that had a longer 6-minute walk test distance. There's been a dozen papers showing similar things, looking at a number of different objective measurements of frailty. I don't think we're great at quantifying frailty. Having almost 20 years of experience in the field, I feel like, I can see a patient in clinic and give them the eyeball test, but that's, that's operator dependent to a certain extent. One of the things that's happened to our program is when we purchased Emory DeKalb Hospital, it came with a very nice rehab center, the Emory Wellness Center. In fact, our surgeon says when we purchased Emory Wellness Center, it came with a hospital. But we partner with the Wellness Center for all of our pre-transplant patients, and they put them through a whole battery of tests, including a 6-minute walk test, something called a short performance physical battery, a sit-stand test, grip strength. And then in our weekly listing meeting, we invite the physiotherapist as one of the team members to give us a rundown. Is our patient frail or not? And if they're frail, what is their prescription for trying to fix that if possible? And so that's been a big strategic goal for us. I have to talk about allocation. And unfortunately, it's going to be hard for me to draw some strong conclusions about this because our allocation model just changed. So what you need to know is by law in the United States, all solid organ transplants need to have allocation systems that are based on patient need. They can't be based on just simply time on the waiting list. And in 2005, we introduced a system called the lung allocation score that ran from 2005 to March of this year. And starting in March, that system completely changed. And that new system is called the composite allocation system, or CAS. And what this cartoon shows is all of the domains that will give you points in the CAS. There's 100 points total. You cannot get a perfect score, but you can get 25 points based on your probability of dying within the first year. You get another 25 points based on your probability of surviving 5 years after transplant. It didn't used to be that long. They changed it. You get 20 points if you're under 18 or under. So pediatrics gets a little bit of a bump. You get 5 points if you're a weird height. If you're super tall or super short, you get more points than if you're average. You get 5 points if you're a hard to match blood type. You get 5 points if you have antibodies to other people. You get 5 points if you've ever donated an organ. And I think what that really means is if you've ever donated a kidney, because I can't actually donate a heart. And then you get maximum of 10 points based on how close you are to your donor. And so it's a complicated scoring system. It's way too early to tell what the overall effect will be, but it was modeled ahead of time to make it so that it would be less likely for somebody to die on the waiting list. And I think what it's going to do overall is it's going to push our country and our transplant network towards transplanting younger yet sicker patients, and potentially at the disadvantage of older patients. We'll have to see. Maybe when I come back and give this talk in 10 years, I'll have more data. Now, we made this talk about challenging the status quo, and so I really want to spend a little bit of time unpacking where I think we've made some differences over the past 10 or 20 years or so. Importantly, it's not a new medication. So with the exception of belatacept, which is a medicine that was designed in kidney transplant for co-stimulatory blockade, which is not even available in lung transplant unless we beg for it, there are no new drugs that for immunosuppression. And I kind of don't think that we're going to really have a eureka moment where we come up with a new immunosuppressive agent that we haven't thought about. So that's not really where the change is going to come from. But what has happened is we have definitely improved our ability to detect and treat opportunistic infections with medicines that have fewer toxicities, that are easier to use. Same can be said for antifungal therapy. I'm going to spend a little bit of time talking about this new concept of cell-free DNA. We have started in the past decade to employ anti-reflux therapy or surgery, like fundoplication for patients who have gastric aspiration. One of the things that's really come along is multidisciplinary approach. We kind of have a medical home for our transplant patients. And so it's not just a pulmonologist trying to wing it. I mean, we have psychiatrists and endocrinologists, and transplant ID is kind of our wingman, and social services and nutrition and spiritual health, et cetera, et cetera. And then I know this is medicine grand rounds, but I have to give a shout out to surgical determinism. Because one of the things that has happened in the field is that surgeons do not give up and have really pushed the envelope. And where they've pushed the envelope is in a couple of different domains. One of them goes back to the case I showed you, which was pre-transplant ECMO. That wasn't a thing before. And now it makes up a big number of patients that we were transplanting, patients who are on mechanical circulatory support at the time of transplant. They have made refinements in matching donors, in donor lung recovery, in lung preservation and reperfusion techniques. And then beyond that, a very highly protocolized approach to getting patients out of transplant and walking and getting them out of ICU as soon as possible. And those are the things that I think have moved the field to date. I want to talk a little bit about cell-free DNA. So most of the fellows will know that we do lots of transplant biopsies on our post-transplant patients, and we basically put people to sleep and put a forceps in their lung and rip out pieces of lung and send them to the pathologist and say what's going on in the lung. Obviously, you can't do that every day, so you have to do it at sort of spaced out time points. And a group at Stanford recognized relatively recently that in organ transplant, you can actually measure in the blood the percentage of circulating cell-free DNA that is of donor origin. And that owes to a lot of DNA sequencing technology that's come online. And what this proof of concept paper actually showed was that you can detect the percentage of donor cell-free DNA, and it rises in the setting of acute rejection. And so this has become a type of we call it liquid biopsy that's non-invasive. And so we've started to use this. The way that it works is we do a lung transplant on somebody, and then at serial time points after transplant, we measure. They actually go out to the patient's house and they measure the blood, and take blood, and they will give us a percent of donor DNA, cell-free DNA that's of donor origin. And then the number that we kind of worry about is 1%. So if it's less than 1%, we kind of say, okay, you're fine. And so what we do in these patients is actually, if they feel good and their pulmonary function tests are good and their x-ray is good or their CAT scan looks normal and their numbers are low, we defer their biopsies. And we've saved people, countless lung biopsies that we used to do. And then we can use this number when it pops above 1%. In this case, this patient was completely asymptomatic. She had mild rejection. We treated her. The benefit of this technology is that it allows us to really hone in and do much more precise, much more real-time measurements before the onset of lung injury, before the onset of some of the things that Dr. Lama is about to talk about. I just want to talk about our experience with COVID because I know people ask me about this, and it goes back to the first case I presented. So in total, we have in 5 EICU, we've had 15 patients that have come down the pipeline who had COVID, who had ARDS. And of those, we've done 5 transplants, okay? And I will say that all 5 of them have done quite well, surprisingly well. And I think that's probably because they weren't that sick before they got the COVID, and they had no other medical problems. We did transfer 2 patients out of those 15 to other programs who got transplanted, and not everybody ended up getting transplanted. We had about 5 patients total who actually got better, which is kind of crazy. And then 2 of our patients never made it to transplant, unfortunately. And there's 1 other patient that's not in here who is still kind of in the works for potential transplant. So my last slide before I hand over the reins is looking at mortality post-transplant. So really what I focused on is early outcomes. Early outcomes pretty good. And we've made a lot of improvements on early outcomes. This is, again, ISHLT data looking at causes of death in the aftermath of transplant. And, we lose people in the first year, but to the first approximation, where we're losing our patients in the first year is infectious causes. Graft failure is really like a technical issue associated with the transplant, something called primary graft dysfunction, and cardiovascular causes. So once we get past that, the major cause of death afterwards is this, right here, it's called OB or BOS, that stands for obliterative bronchiolitis or bronchiolitis obliterans syndrome. But basically what this is talking about is 2 separate entities that Dr. Lama is going to talk about, which you can think about as chronic rejection. And so unfortunately, going back to my patient from the beginning, we don't know where he's going to be in 5 years, but my concern is that he's at risk for graft failure going forward. And with that, I am going to throw over to Dr. Lama.
Thank you so much, David. You can hear me, right?
Yes.
We can.
Okay, excellent. And I'm going to start the part 2 of this presentation. And I think that's going to focus on a very important mission which we have at academic medical centers, which is to move forward a field, not just by challenging the status quo on the clinical side, but also via innovation and innovative research. I'm going to focus on a very small part of lung transplantation. And David gave you a very wonderful, comprehensive overview of how long it takes for us to look at who is right for transplant, who should be listed for transplant. But when him and me sit down and talk to these patients, and all of us in the lung transplant community, when we are talking to these patients, it's really an unfulfilled promise. Because if you look at a 10-year survival of these patients, it's approximately 25%. And it's really not gotten much better over these different decades. So we sit with this patient and we are offering them a promise to live longer, but not very long. And this is a classic example of that. This was a patient very close to me, a patient with cystic fibrosis, referred to us with chronic respiratory failure, which is most of these patients, they're in chronic respiratory failure, either hypoxic or hypercarbic. Got transplanted in year 2005 at age 19. And you can see from this lung function on the right, and there are lots of lines, but you can focus on any line. And if you want, please focus on the sky blue line, because that's the patient's FEV1. And you see the FEV1 went from 28% to 100% post-transplant. So we had this wonderful time when this patient was able to go back to college and do everything the patient wanted. But then in 2009, you start seeing this declining lung function and shortness of breath. It's almost like the disease has come back. And by 2010, this patient's FEV1 has gone back down to 28% right in front of our eyes. And the patient is back in hypercarbic respiratory failure. And in 2012, while I was in the ICU with this patient, we said, we can't do anything. Her CO2 was 120. We had to terminally wean her. And when she died at just age 25, she asked for her lungs to be given to us for research and so that she can help others. So I'll show you what her lungs look like. And it took me some time sitting with the pathologist. When we were looking at her parenchyma, the parenchyma looks great. You see this open alveoli on the side. And we had to scan to find these causative, what was causing this high CO2, which is these scarred up areas, which used to be a small airway. You see this very little lumen here, could be a blood vessel here, but this airway is so scarred up and completely obliterated that we can't even see it. And that's how we see graft failure present. So why are these patients dying post-transplant and not living up to good survival 10-year post-transplant? Is because these lungs start becoming fibrotic over time. And we used to call this bronchiolitis obliterans syndrome. It really was a syndrome because, we came up with this definition and we said, if your FEV1 declines below 80% of the baseline, you have two FEV1s 3 weeks apart, we're going to call you having BOS. And when I was a pulmonary fellow, I said, oh, I'm going to look at these patients and found that they were right in defining it as a chronic rejection because 98% of these patients continued to have a further decline in their lung function and ended up dying from it. We don't get much help from chest X-ray or CT scan because remember, small airways are the silent zone of the lung. You don't see much on an X-ray or a CT other than maybe hyperinflation or mosaic pattern. We don't get much help from transbronchial biopsies either, because as I showed you in that patient, it's a very patchy disease. And so, biopsies are not extremely helpful. They're very good for acute rejection, but not for chronic rejection. So what did we know? 2 decades ago, when I was a junior faculty fellow in transplant, there was some things we knew, but there were a lot of things we did not know. We knew that bronchiolitis obliterans is progressive once diagnosed. We had no clue what predicts its onset, what are the prognostic predictors when it starts, because not everybody post-BOS is going to live the same time. We knew there was variability in the course. Some patients decline fast, some take time to decline after onset of BOS. But we didn't know anything more than that. We didn't understand if there are different phenotypes. And remember, in syndromes, there are always phenotypes. We understood that it's a chronic rejection incited by host immune cells. And a lot of focus actually was on immune cells. It was a lot of immunological research going on. We didn't understand the role of recipient cells or remodeling processes, although in the end, it's a progressive fibrotic disease. So as you saw from our patient there, we had no biomarkers. We couldn't see beforehand that she was going to decline. We had limited understanding of the pathogenesis of this disease, and we had absolutely no treatment. But what we did have was a very unique opportunity, which was, true for most of the diseases which we study, which was a very unique opportunity for translational research. David showed you that lung transplant patients have very protocolized care. We see them at the center, we work them up in a particular way, we follow them in a particular way. And these patients have a tremendous amount of stored data. We have pulmonary function tests we are following, biopsies, CAT scans, clinical data. And interestingly, we hardly ever lose them to follow up other than the patients we lose because they die. Very rarely do they go to different centers. And as David was mentioning, we follow them prospectively with all these samples with biopsies and lavages. In fact, lungs are a very unique organ. I thought felt very excited to study the lung because as a solid organ, we can really go into it as frequently as we want with our bronchoscopy and our bronchoalveolar lavage and biopsies. And we do it periodically over time post-transplant for monitoring and when they have a decline in lung function. So, you couldn't have a better place to study a disease than a scenario like this. So we set up what I like to call as a disease-based investigative unit, which is a very translational approach to studying, to say, we're going to take this clinical cohort. We're going to understand everything about this clinical cohort. We're going to do very good phenotyping so that we know which are the patients who are getting chronic rejection. We call it CLAD now, and I will go into that in a minute, chronic lung allograft dysfunction, with some alert systems in place, which will give us this wonderful cohort for clinical research. We're going to pull their PFTs, we're going to pull their CAT scans, and then we're going to link it to our labs, our basic science side with these tissue samples. And I call it a biorepository, but this is like a continuous flow of tissue samples which are going in. And we now have a very, very well phenotyped clinical cohort, now attaching it to a biological cohort. And then the third arm, obviously, is understanding anything is in vitro, is animal modeling. So we set up this system, and this is, I did that at Michigan when I was there, but all different centers have done it. I know that David was doing it here with using some clinical cohort and the blood samples and lavage samples and the work he was doing with metabolomics. So a lot of us did it, but this is the comprehensive approach we thought was how we're going to try to understand this very important problem of bronchiolitis obliterans syndrome or chronic rejection. So I'm going to show you snippets of data from each, and not more than snippets because there's a lot more which came out, but just to show you what we learned along the way when we look at each of these three arms of our investigative unit. Starting with our clinical cohort, I was telling you that we always thought of bronchiolitis obliterans syndrome as an obstructive pattern in which we know that airways are obliterated, your FEV1 goes down, but your FVC doesn't go down. But what we learned over time when we started looking at these patients more carefully and downloading hundreds and thousands of these PFDs was there were actually two different patterns. Patients who have an obstructive pattern, this is one group, but then there were patients who were declining together. FEV1 and FVC were declining together, and we call this the restrictive pattern. Very easy to plot and to be able to see. And over time, we have understood that these could be two different types of chronic rejection, and we give the chronic rejection the name called chronic lung allograft dysfunction, because really it is a dysfunction and a fibrotic process. But the people who are obstructive have a very different histopathology of small airway obliteration, whereas the patients who are restrictive have pleural fibrosis, parenchymal fibrosis, and this is biopsy from one of our patients, autopsy actually, of a patient who died of chronic rejection, which was restrictive allograft syndrome. What's even more important and interesting is that they behave very differently. Patients who have restrictive allograft syndrome or a concurrent decline in their lung function have a very poor survival as compared to those with BOS. So now this is important because we were seeing this before. We never understood who are the patients who are dying quickly and the patients who could live much longer. And we are really now very interested in understanding whether these different phenotypes are different endotypes. I talk a lot about convergent science, which is bringing STEM technologies into the area which we are excited about as physicians and where we feel passionately we want to make progress. So we have done that in lung transplant, and we have brought, I told you that CAT scan was not very helpful, but can it be helpful? Yes, if we bring in some novel imaging. And these novel image analysis techniques, which can use the CAT scans which we have collected or which we do routinely, can give us beautiful quantitative information. It can take away the inter-observer variability, and it can uncover some features which we don't see when we just look at the CAT scan with our eyes. So one of them which we brought in particularly is called parametric response mapping. It was developed by the Department of Radiology at Michigan, in which they look at voxel to voxel comparison between inspiratory and expiratory images and are able to then quantitate and say if this parenchyma is normal, this parenchyma is showing obstruction, small airway, functional airway disease, or is there an increased Hounsfield density which persists and hence has parenchymal disease. So because of having a wonderful clinical database, we were able to bring this into our lung transplant field when we look at patients who we call BOS versus VAS, or as I said, obstructive versus restrictive decline, and look at these CT scans. We can get these beautiful signatures. In the center is a normal parenchyma. It looks completely green. If on the left, we see that obstructive, we can quantitate the amount of obstruction, and we showed that patients who have increased obstruction greater than 30% functional small airway disease much more poorly. And then we can see increased density, which we might not even see with naked eye. These CT scans on the right, which shows a lot of purple, looks completely normal when you look at it. So really now we have a physiological signature and a radiographic signature, which is brand new. And, important thing is take it back to our patients, and we can take it back to our patients because this CT technology is now licensed to MBio and is available in a lot of centers. And we can look at this quantitative functional small airway disease when we are sitting with our patient in the office and look at what their decline pattern is and how much functional small airway disease is, and identify patients who are going to do very differently. A patient is going to die within the next 3 months versus who is going to have 5 years. So remember, when we are thinking about these patients and we are thinking about treatment, which is going to have significant side effects, like David mentioned, increased immunosuppression, different fibroproliferative agent, retransplantation, we want to think about this, and this is how we have changed the status quo in using some of these novel methodologies to move it forward. I'm going to give you a few examples from the basic science side on what we understood with the lavage samples, which we were taking from these patients back to the lab. When we started, we used to have a very cartoonish, simple way of thinking what chronic rejection is. We would say, a lot of, some of it's not changed yet, but it is that in repeated episodes of immune and non-immune injury, epithelial cell injury, immune cell infiltration play an important role. And then the thought process was, yep, that leads to just fibroproliferation, but not much was understood about it, even though when the patient's progressing, having immunosuppressive drugs after development of chronic rejection does nothing. We just make them sicker. That's because their mesenchymal cell recruitment and differentiation has started, but not much was known about that. We knew about infiltrating immune cells, but we did not, again, know too much about, sorry, I lost my screen for a second here. But we did not know much about the, sorry, can you guys still see my screen?
We can.
You can, right?
Yep. Yeah, now we just lost it.
Okay, give me 1 second. I'm going to screen share again. Here. I'm going to put in my talk. Okay, I'm sorry. You guys can see, right?
Yes.
Okay, sorry about that. So what did we learn from the bronchial lavage? And let me look at the time as well. We have 5-10 more minutes. So when we started bringing these samples back to the lab, what we discovered was something very strange. When we think about bronchial lavage from human patients, we think about immune cells. They're mainly macrophages, some lymphocytes, some neutrophils. But what we started seeing was these colony-forming units. You see these cells? And these are the colony-forming units which are, growing in a dish in our lab, and turns out to be a mesenchymal cell, which nobody knew about. As we understood these cells more, we realized that they are human lung-resident mesenchymal stem cells, or mesenchymal stromal cells. And we could say that they're lung-resident because we could take them from patients who were male patients who got a female lung, or a female patient who got a male lung, and look at whether they were male or female, and found that majority of these cells were resident. So this was very interesting because 14 years post-transplant, we still had stem cells which were donor-derived living in those lungs. This was exciting for all fields because this was followed by kidney and heart showing the same things. But we were fascinated by these cells and as we understood them more, we realized that these cells are actually remnants of the embryonic lung mesenchyme during lung development, and differ completely from mesenchymal cells in other organs, such as the bone marrow mesenchymal stromal cells, and have factors like FOXF1, which are present in a developing lung cell. And I will show you the clinical significance of that in a minute. However, most importantly, going back to the basics, why are we doing this research? To make to change the prognosis for our patients and improve our understanding of chronic rejection. So we asked ourselves these questions that, we are isolating these cells from the lavage fluid. Where do they reside in the lung? Do they have a role in lung homeostasis, repair, regeneration, or fibrosis, which is relevant not just for lung transplant, but for disease like idiopathic pulmonary fibrosis, asthma, other airway remodeling diseases? And what regulates their differentiation and function? So the fascinating part about human research, and especially in a cohort like lung transplantation, is that we had access to these samples over time. So we can look at the number of colony-forming units or the number of mesenchymal cells in the lavage over time post-transplant, which I think is fascinating. And when we look at that in our patients, what we find is that normally these number of these cells goes up post-transplant when there's a lot of repair, regeneration, but then goes back down and stays down. Whereas patients who are getting chronic rejection, the number of these cells goes up, showing us that they have some role in chronic rejection. We did not know whether it was pathogenic role or they're just a biomarker. However, we were very clearly able to show that increased number of these cells late post-transplant after 6 months is highly predictive of future development of chronic rejection, one of the best biomarkers biologically which had ever been shown. And we were also able to show that these cells accompany development of chronic rejection. And if there are a high number of these cells, those patients do poorly after development of chronic rejection. So these cells which we were finding had complete clinical relevance. We then did some more basic science work to understand where these cells reside, via lineage tracing, making some brightly lit mice, and found that these cells actually reside along the bronchovascular bundle in a three-dimensional manner, and that they expand when the patient's airways are rejecting. So these cells are not everywhere. They're only along the three-dimensional manner along the bronchovascular bundle. So, we now understood that these cell is the relevant cell. It's around the airways. That's where we are seeing the fibrosis. And they're also along the pleura where we see the fibrosis in RAS model. Because we are able to isolate these cells from patients with and without chronic rejection, it really gives us this opportunity to understand what goes wrong with this cell. What are the mediators? What are the activated pathways? Why these cells are becoming fibrotic? And why is that important? That's extremely important because tomorrow we're going to use therapeutic approaches to target these cells. And I'm not going to go into some of these manuscripts or papers, but some of the things you see here, autotaxin, mTOR, JUNK, there are inhibitors for these which are already out, some in the cancer field, some in the other fields, which we now have the possibility of bringing into lung transplantation. So we have learned a lot from this disease-based investigative unit, but we understand that till we have good animal models, we are not going to be able to understand from phenotype to endotype. So we need animal models which can mimic human pathology, and then we can use also things like autotaxin inhibitor, like I said, and show that they are relevant because we have used them in preclinical models. So our lab, we have developed 2 mouse models of chronic rejection. I'm going to give you a very brief thing about that, which is that we take an F1 generation mouse, which is a progeny of the 2 parent mouse, DBA2J and C57 Black 6. Now remember, this is going to be half of this, half of that. So there's going to be rejection when you put this lung into this parent mouse. And what's interesting is that one of them gives us the one phenotype of bronchiolitis obliterans syndrome, and the other gives us the other phenotype of RAS. And you don't have to believe me, but David will tell you this histopathology looks exactly like what we see in our human patients. So we are very excited because we have these 2 mouse models. And how it ties together is because now we can compare these 2 mouse models and understand why some of our patients develop BOS and some develop RAS. We always thought that patients who develop restrictive allograft syndrome, remember the very fulminant phenotype where their lung function declines very rapidly, and in front of us, we lose them within a few months, that these patients sometimes have high HLA antibodies. And we had some thought process that maybe this is more humoral immune response. Our mouse model comparison completely demonstrated that to us, showing that there's B cell activation, humoral immune responses, and if we take away B cell by using B cell deficient mouse, we don't get this pathogenesis of RAS. So this is the first time where fibrosis has been linked to different immune skewing, and we are very excited about that. We also understand that our bronchovascular bundle MSCs play a very important role in establishing the immune niche, and this is some of the work of one of our funded awards. And hopefully it will be published soon, and I can give you reference at that time. So what have we understood? We have understood via this very interesting model of using this 3-pronged approach that clade has different phenotypes, that there are novel transcription and translational regulators which we can use for therapy. And in this process, we discovered a new stem cell, which we are pretty excited about because it's relevant to entire lung. And we have given the field 2 new mouse models of transplantation, which we are hoping will lead to many more discoveries. But I must say, really, if we want to change the status quo in any disease, the most important thing which we have learned is that collaborative research is the most important thing. Focusing on our clinical programs and using our clinical programs to then make the translational research happen is the way to go. And we have to continue to evolve and challenge the existing dogma. But most importantly, we have to invest in our future generations because somebody taught us all this, and this is what we need to pass on. So for those of you who are sitting in the residence room, medical students, fellows, you know that all this work which we have done hopefully I won't be presenting it another 20 years or 10 years, but you will be. And I hope what you show for lung transplantation is this new line of survival and the next era. And this is what we are hoping for with this work which has been done in the last decade. I'll end here and I'll stop sharing so people can ask us questions. Thank you.
Thank you so much. That's both really fascinating, and it's very, very cool to see you tease these, phenotypes apart with these different models. Question in the chat from Carrie Espenson, who says, you mentioned many partners, but not palliative care. Despite the fact that these patients have high risk for decompensation and death, is there any work on partnering with pal care to address things like advanced care planning and anticipatory support for when things go bad, or are there barriers that prevent that?
That was a complete oversight on my part. They're 100% part of our team.
Dr. Stevens, I see your hand up.
Yeah, let me get off mute. First, let me thank both of you for a great presentation, really from the clinical perspective to the basic science of rejection, really fascinating. I guess my question is for David, and it's a simple question about one or two. I mean, the data you presented indicates that there's really not a lot of survival difference between 1 and 2. And while I appreciate there are probably timing and match issues with the availability of organs, it seems like we would significantly increase our number of transplantation of a number of organs by really looking at 1 as opposed to 2 lungs. Can you kind of comment on why that still seems to be 2 is better than 1?
This is a really hard question. I mean, there's certainly cases where 2 is better than 1. The data get very murky at the boundary line, around 55, 60 years old. It seems like there's a crossover point. Single is better in the short term, probably worse in the long term. And so I think a lot of what's happened is the surgeons know that, patients know that, patients talk. They're super engaged with each other. We've had a couple patients this year who were listed for single. We called in and they said, I thought about it. I talked to some of my transplant friends and they said I should really get a double. So it's quite messy.
So David, I'd like to add to that to respond to David's question is, David, we did a study years ago and we looked at the time of onset of chronic rejection, single versus double, what were the FEV1 and what was it a few years out. There is no question that even when you have onset of chronic rejection, patient with double lung transplant will have higher lung function, better quality of life. And then along the way after chronic rejection, because they're starting at a higher baseline, they will have a higher lung function. So there's no question that if you compare lung function by itself, there's difference between single and double lung transplantation. So, there is different people have shown different data. There's definitely improved survival.
Yeah, I was reacting to the Kaplan-Meier curves that you showed that really didn't seem like there was a significant long-term survival advantage. A slight one, but only a slight one between double versus single.
And then the other thing, David, also being that there's a lot of patients who cannot get a single, like David mentioned, CF patients. So the tradition has been, at least this what we have done before, is cut off by age. Below a certain age, we offer double. After a certain age, single, but also depending on the disease. But jury's out on that yet.
All right, we are past the top of the hour, so I'm going to cut off questions there. Sorry, Charlie. But thank you guys so much. This has been really, really inspiring and instructive.
Thank you, Ellie.
Thanks.
for the opportunity. Bye.